Dr. Chinnabhabu Sunkavali, I would request you to introduce our keynote address speaker, Dr. Nori.
Thank you, Satish. Well, it's my privilege and honor to introduce our keynote speaker for today, Dr. Dattatreyudu Nori. He is not only a professor and director of the cancer centers at Presbyterian Hospital and Queen's Weill Cornell Medical College as well, but more importantly, he is very connected to us because he is our advisory board member at Grace Cancer Foundation, and he is a very well-known, renowned name globally in the field of oncology, more so in the field of radiation oncology. He is a recipient of Padma Shri Award, and he has done marvelous work in the field of brachytherapy. He comes from Machilipatnam district, Andhra Pradesh, did his medicine from Kannur Medical College and post-graduation from Usmania Medical College. And more than anything else, his zeal to give back to the community back in India, that is something that really connected us, and we're really honored to have Dr. Nori as our keynote speaker for today. Welcome, Dr. Nori. Thank you so much for all that you do for Global Grace Health and Grace Cancer Foundation. Welcome.
Thank you. Thank you. Can everyone hear me?
Yes, sir. We can hear you.
Okay. Good morning. Good evening, wherever you are. Thank you, Dr. Chinnabhabu, and all the advisory board members of Global Grace Health internationally and Grace Cancer Foundation in Hyderabad, India. I'm very delighted. I'm very happy to participate in this Global Grace Health second anniversary meeting. And let's start with the next slide. Okay. This one, follow the extreme on the left side. Global cancer cases estimates 2015, 15 million, 2035, which is not too far, is 24 million. And where are these cases going to be? In developing countries. So unless the only way these projections can be modified or reversed is through organizations like you. I wrote an editorial in Times of India last month, how to address the cancer burden nationally and globally. All the advances which I'm going to show in the next few minutes about advances in molecular technology, innovative technology, clinical trials, clinical innovations, all that is part of the story that will address patients who already have cancer. But the only way we can bend the curve, we can reduce the cancer burden globally and nationally is through what you guys are doing. I really admire your association, both the Global Cancer Health and also Grace Cancer Foundation India, introducing the concept of cancer awareness, screening, and early detection. These are the three mantras if you want to change these projections of from 2015, 15 million new cases globally to 24 million new cases in globally in 2035. And to bring the point home, in India, 200 women are dying of cervical cancer every day. 1,600 of our citizens in India are dying per every day. These are alarming numbers. Why they make us feel bad as oncologists, as something that we are all doing, trying to do in oncology, is 2/3 of the cancers in India are preventable. The next statement is they are preventable but not prevented yet. Very important statement. The organizations like yours will make it happen. I'm very proud to be associated with your organization. Next slide, please. Now I will show you the other part of the story, clinical advances. Is cancer a death sentence? No. There's so many advances have happened in the last 25, 30, 40 years, which I have witnessed, and I have contributed to some of the advances from Sloan Kettering and New York Presbyterian Cornell University. I will make it, even though some of the slides may look complicated, I'll try to make one point to make sure everyone understands what is there. Evolving paradigms, new discoveries in cancer, advances in clinical oncology. Next one. evolving paradigms. This is not a rocket science. What we used to do when many decades ago is look at the size of the tumor, the histology, the pathology, the grade of the tumor. That's no longer the case. We now have markers. We look into markers, ploidy and receptors. Now the tertiary predictors are we look at the gene expression, EGFR expression, molecular and proteomic profiling. What in simple terms, our understanding and the molecular underpinnings of cancer, we understand much better now than before. This is very important. This slide may appear very complicated. I'll make it very simple. Take, for example, a wheel, a bicycle wheel. It has spokes and a center hub. The center hub is the nucleus, where you see the central bluish structure is the nucleus, the DNA. And the DNA gets multiplied. In the past, we didn't know what signals this DNA to multiply and become a tumor and metastatic cancer. And about 20, 25 years ago, we came to know that the signals for the DNA to multiply is not coming from the center, from the periphery of the wheel, that is the periphery of the membrane, all the signals. One signal coming from the periphery of the membrane telling the cancer cell, multiply, multiply. The other signal is telling the cancer cell, get your own blood supply. The other signal is giving a signal to the cancer cell, develop your metastasis to the lung, brain, bone. So these are all the signals. Then what we did through our technological advances in molecular sciences, we developed these targeted drugs or designer drugs to block each signal. If I block one signal, that kind of activity from the cancer cell, it disappears. For example, metastatic potential, or developing its own blood supply, or lung metastasis, brain metastasis, all those. So we found all these in capital, in their bold letters, transmembrane, Herceptin, cetuximab, rituximab on either side of the slide. These are all targeted drugs to block those particular signals. Was there any impact in cancer cure rate by targeting these signals? Of course, yes. Next slide. Next slide shows these targeted drugs made significant impact in improving the cure rates of several cancers. For example, Herceptin for breast cancer improved the cure rate by 30%. Avastin, that tells the cancer cells to not to produce its own blood supply or curtail on the blood supply, produced significant improvements in lung cancer, ovary cancer, and colon cancer. Rituximab for lymphomas improved the cure rate by additional 50%. Erbitux head and neck cancer, Tarceva in lung cancer. Tarceva, I'll just give you one example. Tarceva, some of these targeted drugs are not even injections, they are pills. If you take a pill, especially for head and neck Tarceva, stage 4 lung cancer patients can survive 10 years. I have so many patients coming from India to see me in New York with these particular signal modification, and we put them on these drugs, this particular drug Tarceva, they survive 10 years, even if they have metastatic disease, without any problems, they survive, without any symptoms. Gleevec for chronic myelogenous leukemia, this is a pill, tyrosine kinase inhibitor. This pill will cure chronic myelogenous leukemia, cure. The next one is for multiple myeloma. So the take-home point here is the next development in cancer field is the targeted drugs, which are helping to improve the cure rate. But if you, for any common man or oncologist, the next question is, each drug is working on a single signal. It's blocking one signal. But cancer sometimes is a complex disease. It may be due to multiple signals. So what is that treatment available that can turn off all the signals coming from the cell membrane or the wheel of the bicycle? That is immunotherapy. Immunotherapy will turn off all the signals from everywhere and improves your own immunological stimulation to fight the cancer. It's a paradigm change. It's a incredible innovation in cancer treatment is immunotherapy. It's going to change pharmaceutical companies in America and everywhere. They're spending billions of dollars on developing new drugs for immunotherapy in cancer treatment. Go back to the previous one, please. The immunotherapy, I will make it very simple to understand. As the cancer cells grow in the body, it produces two antigens or nasty materials to knock down your command and control system in the body, which is your immunological system. So two nasty substances produced by cancer cell as it grows in your body, or one is called CTLA and the other one is PD-1. Forget about the names, but the two nasty substances are produced by the cancer cell to destroy the immunity in your body. Go to the next one. Next one. These are the CTLA and PD-1. Next one. Then next one. Next one. Okay. You can go to the next one. Okay. The combination now, we came to know that when you combine radiation, chemotherapy with immunotherapy, there are several patients surviving many years, 10 years, 15 years, which we never heard with a metastatic disease, people surviving that many years, free of cancer, free of cancer. This is one example. I don't know whether you can appreciate. This is a patient early on in our studies, has a lung cancer with a metastasis to the liver. You can see on the left-hand panel, liver metastasis and base of the lung metastasis and pre-sacral metastasis in the pelvis, in the body. And we treated him with immunotherapy and radiation to the liver, with a few treatments to the liver. And this patient is alive at 14 years now with all the scans being clean, PET scan, and living well. These are some of the most gratifying examples you can see using immunotherapy with other standard care like radiation and chemotherapy. Next one, please. Our US president, you all know, he has cancer with metastasis spread to the brain, bone, lung, and liver. If we don't, in those days, the treatment, whatever we offer, he will have a survival of only 6 to 8 months. We treated him with local radiation and immunotherapy. He is now 12th year, free of disease, going to 13th year, completely all the scans are clean, and he's now 93 or 94 years. Next slide, please. Why am I showing these two individuals? I mentioned before, cancer as it grows in the body produces two nasty substances to knock down our immunological command and control center in the body. And those two, the first one is PD-1, discovered by this Japanese scientist, MD, PhD scientist. The second one is CTLA-4, is discovered by our New York scientist, James Allison. Those two people got one Nobel Prize for discovering those two nasty substances. Now we know how to destroy those nasty substances in the body with using what is called immunomodulators. So this is a game changer in cancer treatment. Next slide, please. Genome Atlas, produced during the term of President Bill Clinton, gave us so many clues and molecular underpinnings of cancer. Next one. Next one. Yeah, this is, I'll describe to you what kind of information was useful from this cancer atlas, genomic atlas, produced many decades ago. If we have 100 patients with lung cancer, for example, or breast cancer, all of them have stage 1 cancer, same size, same pathology, same age group. We treated them with same mantra, same therapy. 70% of them are cured, 30% of them are not cured. Why is that? It's the same size of cancer, same stage, same biology, same pathology. Go back. Then we came to understand that the molecular underpinnings of that particular cancer in particular individual is not the same as the other next patient. We came to know only through this molecular research. Then next one, the drugs we use, what we were using on those 100 patients is the same medicine, same mantra. But in this standard group in the center, this has multiple molecular types of cancer, even though same stage of cancer. For on the top green panel, the drug we are using was toxic and beneficial. The other side, magenta, is drug toxic but not beneficial. On the bottom, drug not toxic, not beneficial. The yellow. The blues are drug not toxic but beneficial. You see here, small group, this is the group you want to use the drug. Drug is not toxic but beneficial. But in the past, we are using the same drug on those 100 patients, and all the other three groups is a totally waste of their money and waste of our time to experiment the drug on them, even though everyone has the same type of cancer. The take-home point here is not all cancers, even if they have the same stage, are identical. Their molecular structure is different. So based on these molecular structure nowadays, what we call in Hyderabad, in India and here is called next generation sequencing, what is called NGS. If you do NGS, it will tell us whether that drug is going to be useful for that individual patient. This molecular profiling studies, next generation sequencing, both for cancer and other diseases, you can predict at what age group a particular individual will get what type of cancer. This, for example, there is a P3, clear cell carcinoma of kidney is due to one loss of P3 chromosome, and mutation of this can produce the earliest event in the tumor evolution of kidney cancer. So if they have that mutation, you can say this gentleman at the age of 50 will develop kidney cancer. So we have that kind of advances in cancer molecular biology. Next one. Advances in clinical oncology. This is, you will understand much better about clinical advances. What I have shown you is the evolution of advances both in targeted therapy, in immunotherapy, and combination of immunotherapy with radiation and chemotherapy. In radiation, there are many advances in technology. The technology has taken over the field of oncology, especially with radiation. Next one. And we are now using stereotactic techniques to precisely treat the cancer wherever it is, in the pelvis, lung, brain, or pancreas, anywhere. What is that important? Why it is important? When the precision improves, you can cut the margins and treat only the lesion. So the toxicity significantly disappears when the precision improves. When the precision improves, you can deliver higher doses of radiation. So you don't need 6 to 7 weeks of treatment for this particular cancer. You can deliver that in 2 to 3 fractions because the treatment is incredibly precise. Next one. And this same patient treated with stereotactic body radiotherapy with high precision treatment. You can see here at 5 years on the other extreme panel, you don't see the cancer at all at 5 years with no significant complications or toxicity in the surrounding lung. Next one. Another game changer in radiation treatment is the proton therapy. Very few centers have proton therapy centers. Even in India, there is only one at the time being. They are getting another one in Hyderabad. In US and Europe, we have many, many centers. I will just go to show you how precise these proton treatments are. Next one. It's a very expensive technology. Eventually, the price will come down that every country will be able to offer this treatment. These treatments are so precise. Next one. Next one. Next, yeah. You can see here on the standard radiotherapy, when you apply the deep beam, the beam goes through and through the body. You can see that purple light going through and through. On the other side, proton therapy, the beam will go and treat the cancer, and there is no radiation behind or around it, unnecessary radiation. So it's so precise, the beam will not travel to other parts of the body. So if that is the case, where is the indication for this? In what cancers? Is pediatric cancers? In central nervous system cancers? This particular proton beam therapy is extremely, extremely useful. Hopefully that will be available in many centers in India and globally. Next one. Next one. These are all just animation slides to show how precise. Now we are combining standard linear accelerator with MRI technology, the magnetic resonance technology, where the precision has improved 100-fold. So we are delivering treatments with a few fractions. The patients come to us in Manhattan, if it's a lung cancer, pancreas, or liver, or brain, we do the planning and we treat them with what we call Vure, MRI plus LINAC combination in less than 5 fractions sometimes, or 1 to 5 fractions in lung cancer cases. And the cure rates are extremely good and complications are very, very low. Next slide, please. Next. These are some examples of how precise, because you can see the target, which is the cancer, in real time. The beam goes on only when the target falls into your dosimetric outlines. If it is outside, the beam turns off itself. So it is so precise. This is going to be another game changer in oncology. Next slide. And India, also the first machine will be coming up in Hyderabad very soon. The treatment of the pancreas, day 1, see the tumor, if you press on the, it will show the animation, yes, okay. You see the tumor in the pancreas on day 1, day 2, keep moving, day 2, yeah. See how the target is moving? If you use the same beam, standard beam, you will be treating only part of the tumor. Adapt, it's adapting the beam to the shape of the target second day. Next one, continue. See, go to the third day, it went superiorly. So the target now is moving. So the beam also moves with the target. So this is adaptive radiation, which is another game changer in oncology. Next slide, please. The same thing in lung cancer also. You can go through the next slide or show the animation also on this slide. Especially in lung, the tumor in the lung moves with the lung. If you don't do adaptive radiation, you will be treating normal lung on day 2, day 3, day 4, not the target. Okay, press on the next one. It will show you how it moves. Next one. And next one. So is adaptive radiation, the target is always within your beam. Next one. There is an animation for the prostate treatment also. Push the prostate, you can see the bladder, the rectum behind, and the red line is the prostate. Red line shown is the prostate. Look at with each movement of the abdomen respiration, the target is moving up and down, sideways, superiorly, inferiorly. Unless you do adaptive radiation therapy, you will be missing half the target every day and tell the patient, we're sorry, we are not able to cure your cancer. The reason was half the time the beam is off. Our target is off the beam. You can show this in this animation. Okay, now come to the breast cancer. You can go to the next one. We made significant advances in breast cancer. Lumpectomy is the standard of care, and lumpectomy followed by radiation. For those non-oncologists, remove the lump in the breast and add radiation. The cure rates are identical as if you remove the entire breast. So more and more people all over the world, not only in US, India, and Europe, all over the world, the standard of care is lumpectomy, remove the lump, follow that with radiation. The radiation, next slide. The radiation used to be 5 to 6 weeks of radiation. People, living in big cities like New York, Manhattan, they cannot afford to come every day, Monday to Friday. So what my team has done innovative clinical research. Do we need 6 weeks? Can we go with only 3 weeks instead of 6 weeks? We did that clinical trial. The treatment outcomes are excellent. So then we moved to 3 weeks. 3 weeks to 1 week, the outcomes are identical with a different technique, different technology, and the cure rates are incredible. The complications are extremely minimal. So we moved to 1 week. Now, at the time of lumpectomy, we give single dose radiation. The single dose radiation is equivalent to 6 weeks of radiation. So the point here, take home point, when a standard of care treatment works, then we try to improve on how we can make it user-friendly, patient-friendly, to make the treatment duration shorter and shorter, that they can come, they have the lumpectomy and radiation on the same day, go home, and the cancer is cured. That is kind of clinical research I would like to encourage everyone in other institutions to continue doing it. Next one. In prostate cancer, we did the same thing. You don't need prostatectomy, or in selected cases only you need to remove the prostate. But other cases, the same way I have shown you with breast cancer, the treatments are condensed from 7 to 8 weeks to 3 weeks to 1 week to 1 day. Next one. These are some of the techniques I developed, which are used all over the world. Simplifying the treatment to 1 day. The patient comes in the morning. I get a lot of patients from India and Europe. We do the scanning and the procedure. He's ready for a procedure in the afternoon. He goes home in the evening. Then we treated thousands of patients like this. All my students who are trained by me are practicing these techniques all over the country, all over the world. Next one. Next one, the outcomes are really, this gentleman, you all know. Next one. Next one, yeah. You all know the mayor of New York and one-time presidential candidate in the US. He's in the news everywhere. He has prostate cancer treated with single-time treatment, outpatient treatment. He is now 18 or 19 or even 20 years following the treatment. Next slide. There's so many techniques we developed. I will not go into details. These techniques have made significant impact on improving the cure rates. Otherwise, the patients would have lost their life. They will be gone in 6 months. And this particular one case, I will show you example. Then this patient, for those clinicians in the audience who know, the X-ray on the left shows a big mass in the right upper lobe. That mass, the right upper lobe, the other side. The white shadow on the right upper lobe. And this mass has invaded the spinal canal, vertebral body, and ribs. And this patient would have had only 6 months to live with this kind of presentation. And we resected the tumor, used some kind of innovative intraoperative technique, and gave radiation to the surgical bed intraoperatively. And this patient survived 10 years after treatment. And even though it's a single case report, I published that in JAMA, Journal of American Medical Association. Even though it's a single case report, this case was published in all the languages of JAMA, Japanese, Chinese, Spanish, everywhere, because this treatment was so innovative. Next slide. This is after removing the tumor. You can see the removed lung tissue with what is shown in the upper superior aspect is the tumor. And the margins are positive, so we use the intraoperative technique. Next slide. These are published, and all my fellows and people who work with me practice these techniques all over globally, everywhere. Next slide. One of the persons who this technique was more advantageous, and I used that, is our president, Sanjay Reddy. I had lung cancer, diagnosed in All India Institute, Medical Sciences. And they sent him to America, to our center, Sloan Kettering. And because he was a smoker, chronic smoker, he could not be resected. So we did the intraoperative technique on him. He survived about 18 or 19 years following the treatment. And this is one of the most gratifying examples of how a teamwork, working closely with all the oncological team, will benefit the patient, especially in this case, President of India. Next slide. So many other examples I can give. This child is a 20-year-old kid with a tumor in the elbow. You can see that nasty lesion you can see in the elbow. He has multiple treatments in the past, went to Harvard, Stanford, everywhere, and they all recommended to come to Sloan Kettering. And he came to us. This treatment, in this case, they all offered at other places is take out the limb, cut the limb. That's the only treatment they offered. But here, being we're innovative institutions, Sloan Kettering and Cornell, we devised some new treatment where the tumor is resected, and we placed intraoperative radiation just for the 2 days period he was in the hospital, and put the graft on the resected side. And the slide with where he is holding the pen, he is 22 years following the treatment, and he is holding the pen. Why am I showing that? Is he not only is cured of the cancer, his function in the hand is preserved. So these techniques, whatever we develop, should cure cancer, but also maintain the function in the limb. Next slide. This is another example. What if you can see on the CAT scan side, you see a central mass, big mass. This patient came to me from Israel, has a hysterectomy for a cancer, and the cancer recurred within 6 months. And she went to UK and other places. They all said, we cannot cure you. It's only 6 months or 8 months to live because it is unresectable lesion. So she came to us. We designed a new technique, as I mentioned to you. We always take up challenging cases coming to us from everywhere. And we designed a new technique. We used the technique on her. You can see on the date on the other side is 1987. She continues to do well. This is nearly 25, 30, even more than 30 years. She continues to do well. The take-home message here is you have to understand the biology of cancer, how it is behaving in that particular individual, and develop treatment techniques based on that. In this patient, the biology is showing that it is going to be locally aggressive, not going anywhere. So we developed a locally aggressive treatment for her, and she survived 32, 33 years. And she sent me a New Year card every year. This year, last month, she sent me a New Year card saying, Dr. Nori, we just celebrated 60 years of our wedding anniversary. And the next sentence was very gratifying to me. 60 years of wedding anniversary, we celebrated, 30 years of which is given by you. So these are kind of inspiring stories that make you do more in oncology to help more patients nationally and globally. Next slide, please. So advances in oncology, to summarize, progress in cancer treatment will increasingly utilize individualized treatment strategies based on complex molecular biology of most cancers. One treatment doesn't fit all. It has to be individualized. Modern pathological characterization, the so-called NGS, will determine which tumors will respond to a particular therapeutic approach. That is already here. Targeted therapies with drugs aim at EGFR receptors, tumor, environment, and angiogenesis are all here. Immunomodulation, either alone or in combination with radiation, will enhance the outcomes in majority of the cancers. I'll submit one case in point. Stage 4 lung cancer patients used to have a 5-year survival of 4%. Now it is 25%, which is a significant improvement in the outcome of stage 4 lung cancer. Thank you very much.